Chapter 18, gastrointestinal emergencies. A lot of what we're going to talk about today, more than actually being able to realistically actually figure out what is wrong with someone, is going to be the anatomy and how these problems present. Because in the field of emergency medicine, actually figuring out the wheres and what fors and what is actually wrong with someone who's having abdominal pain is next to impossible. These are things that are only diagnosed under imaging, only diagnosed under lab work, and for the most part, our job is going to be to manage the associated signs and symptoms and know what could be wrong so we know what to expect next. We have hollow organs, we have solid organs, and each of them is going to present to us a little bit differently. Each of them is going to present sort of their own little unique bit of challenge. So when we assess the abdomen, knowing where things actually physically are inside of the person is going to be sort of our bread and butter here. So in that case, let's talk about the structures. In the abdomen, I already mentioned, we have hollow organs, we have solid organs. Those solid organs, your liver, your spleen, your pancreas, your kidneys, they are very, very vascular. They have a very large blood supply, and in such, when they are subject to illness or injury, they have the tendency to bleed a whole awful lot. These are the organs that we think about in traumatic events that will actually fracture and cause that humongous amount of internal bleeding that we talked about, and all of that blood just free floating in the abdomen, no longer supporting perfusion, and can really lead to hypovolemic shock and hypoperfusion of our patient. These hollow organs on the right side of the picture, most of those are going to be organs of digestion and excretion. These are the things that are breaking down all the food that we take in, turning it into energy, turning it into nutrients, and then further on down the line, turning it into waste products. These hollow organs, their job is to house nasty bits, right? Things that are gross and filled with bacteria and really just aren't meant to be anywhere but inside of that hollow organ. So that being said, when one of these organs happens to rupture or have some sort of disease process that makes it no longer functional at its job, we think of all of those contents spilling into the peritoneal space. The peritoneal space is inside of your abdominal cavity. Just like with our lungs, the visceral and parietal pleuras that we're going to talk about here, the pleural linings that hold your abdominal organs where they're supposed to be and keep them from rubbing against things and creating inflammation and creating problems. When we have a problem inside of that peritoneal space, it's going to present to us in certain ways, and that's sort of really what we're going to talk about most today. Actually being able to physically really know what is wrong with someone, very, very difficult. There are certain things like gallbladder problems or kidney stones that have absolute hallmark signs and symptoms that we'll be able to be very familiar with. But most of the rest of this stuff, abdominal pain is abdominal pain and the world is round. It's more about taking care of our patient at that point than taking care of the problem. When we assess the abdomen, we are going to draw a quadrant. It runs through the midline of our patient and it runs through the umbilicus of our patient. We separate into right upper, right lower, and left lower, respectively. And if you look at our upper quadrants, what do we see mostly in those upper quadrants? Are they going to be hollow organs or are they going to be solid organs?
Solid.
Yeah, they're solid organs. So those are the ones when we see and have a patient who's complaining of pain or recently sustained some sort of injury to that area, those are the organs that we're immediately thinking of as a bleed. Those organs, when they are injured or when they are ill, have very point-specific tenderness. Your patient will be able to tell you, it hurts right here. In the lower quadrants, where we have all of those hollow organs that really their job is just to house things and move them along, when a patient has lower quadrant abdominal pain, normally it's very diffuse and spread out because those organs don't have the same sort of receptors. They don't have the same sort of issues. Your patient isn't able to just point and go, that little piece of my intestine right there hurts. It's not the way that that type of abdominal pain works. So now let's talk some pathophysiology of our abdominal pain. There is 3 ways that realistically all of this works. We're going to have a mechanical force, so some sort of stretching, some sort of traumatic event. Inflammation, which is just irritation and aggravation and swelling of all those cells and all those tissues, or ischemia. And when it's an ischemic problem, it is just like all of the other ischemic type problems that we talked about. It is relative to blood flow. Your gastrointestinal system, the wealth of what is housed in your abdominal cavity, is surrounded by what's called the mesentery. It is all the veins and arteries and arterioles and venules and capillary beds that actually, first of all, allow those cells to do what they do. And secondly, allow all of those nutrients that your gastrointestinal system is breaking down to actually get out into the bloodstream and accomplish the mission of creation of energy. That's what this whole thing is doing. Your gastrointestinal system is taking the food that you eat, turning it into energy, and that mesentery that surrounds all of it is turning it into energy, period. So if we have a mechanical problem, that's pretty simple. Some force has been applied to these structures that has caused injury or illness, generally injury. Inflammation and ischemia are generally what we think of when we think illness. And now we're going to talk about what actual types of pain your patient perceives and how it is going to be relative to our assessment. So depending on what organ is involved, abdominal pain is generally classified as visceral or parietal. Visceral pain means the organ itself is generally what's involved. It's generally less severe, poorly localized, sort of a dull, achy kind of pain when we talk visceral pain. Generally, visceral pain is associated with some nausea and vomiting. Parietal pain is much more commonly associated with that irritation in the peritoneal lining. The pain is more sharp in nature. It is typically very constant, and it can be diffuse and spread out, or it can be sometimes very point tender, very specific. Visceral pain can also be called referred pain as well. That referred bit that we ask, is that pain right in that one spot or does it move around? Think of the way our body is wired and all of those neurological pathways. They have to pass through plenty of tissue in order to get down to the business end where they're going to actually accomplish their functional task. So anywhere along that nerve pathway, your patient may feel referred pain. It's the same with chest pain. When we talk about cholecystitis or a gallbladder attack in just a couple of minutes, we're going to talk about referred pain as being one of the big hallmark signs and symptoms of it. And referred pain is very clinically significant. That's why it's in our assessment. Go figure. So we're talking about the abdominal cavity. Anytime you see the suffix itis, itis, in medical terminology, that means inflammation. So this word right there all by itself means inflammation of the abdominal cavity. Peritonitis is generally caused by some sort of bacteria, chemical, blood, pus, you name it, building up in that peritoneal cavity and causing all sorts of inflammation, irritation, and pain. It's not that like very spot specific. Think of it this way. If one of those hollow organs decides to no longer be intact or decides to no longer effectively accomplish its job, maybe your patient has a bowel obstruction or something like that, and all of that bacteria is building up. And the more that things build up, the thinner the wall of that intestine gets. Sooner or later, some of that bacteria that's housed in that abdominal contents is going to start to leak out. And it's going to start to leak out into the peritoneal space. And that peritoneal space does not want all of that stuff in it. And when it starts to leak, it's going to cause inflammation, irritation, and pain. Signs and symptoms for our peritonitis is just going to normally be pain or tenderness, some nausea, vomiting, diarrhea. The medical term anorexia that you probably saw a whole bunch of times in your book is not the same as the clinical condition of anorexia. Anorexia, when we talk about it as far as a patient with abdominal pain, is going to be someone who just is so ill they don't want to eat. Physically, they are almost unable to do so. Anybody here ever had this? Everybody out there still got their appendix?
Yes, I got mine.
All right. So we see the word itis, and I just gave up the farm and told you that it had to do with the appendix. So this is inflammation of your patient's appendix.
Looking for you. You hungry? You want to eat? Or are you gonna play first? Oh,
So this is one of our major causes of what we will call the acute abdomen. The acute abdomen just means it's an emergent call for abdominal pain. This isn't something that generally um, turns into a patient who is rapidly trying to expire right there in front of us, because most of the time this pain is significant enough that patients don't mess with it. The way this appendicitis works is the appendix begins to become inflamed and it begins to sort of swell. And that swelling is going to cause some pain in the right lower quadrant. That swelling is going to also be felt sort of in the periumbilical area, so it's kind of spreading towards your patient's umbilicus. And with that appendix swelling and getting more inflamed and more irritated, the wall gets really, really thin. Now, in really young children, or younger children anyhow, and elderly patients, when that appendix wall is beginning to thin, it's very prone to perforation. Now, this is a hollow organ. It's got all sorts of nasty stuff inside of it that should not be free floating in the abdominal cavity. When that wall starts to thin out, all of that bacteria, all of that crud begins to leak from the appendix into the peritoneal space. And realistically, this patient is acutely ill. This patient is going to require surgical intervention. They're going to complain of some nausea and vomiting. They're going to have generally a low-grade fever. They're going to be guarding that abdomen. You see the position that this patient right here is laying in with her arms folded across her belly, looking like she would do anything and everything in the world to keep you from poking at that stomach. That's because this is so inherently painful that she would do anything to keep you from poking at that. When we're going to assess an abdomen, generally this will cause some bit of increase in pain. If you start in whatever quadrant is the furthest away from where your patient's abdominal pain is, you're going to get more clinical significance out of it. Because when something is painful, what happens when you touch it?
it hurts.
Yeah, and it drives the pain way, way up. And you know what happens for every part of her abdominal quadrants after that? They all hurt.
Yeah.
We're not really trying to increase our patient's pain to an unlivable level. We're just trying to see if I touch that spot, does it increase the pain? We're not like deep tissue massaging to try and see if there's something we can feel. If there is something to be felt in your patient's abdomen, believe me, you won't have to push. When we assess an abdomen, we're looking for soft, non-tender, non-distended. And just like when we talk about what color should our patients present to us at, what should their skin color, temperature, condition be? And we've made the argument that pink, warm, and dry is the color. That's the color, temperature, and condition we hope for. If your patient's abdomen, wow, is not soft, non-tender, non-distended, guess what?
If it's not soft, not tender, not distended, then there's something wrong.
Yeah, if it's not
It might
soft,
have ruptured.
regardless, realistically, and I mean this, regardless really of what the problem is, with exception of a couple of few things that we can sort of armchair figure out and know that this patient is probably more acutely ill than they're presenting, like appendicitis, all we can do is report our findings. I left my x-ray eyes at home when I left the house this morning. So ultrasound is just out of the question as far as I'm concerned. We treat the signs and symptoms. We let this patient lay on the stretcher in a position of comfort. If this is how she's comfortable, other than I would want her laying on the other side so I could monitor her airway, that's how she goes on the stretcher. Your patient who's got a significant acute abdomen is not going to want you to lay them out flat on the stretcher, because that stretches out those abdominal muscles and it makes the pain even worse. So think about how you're going to treat this patient and assess this patient and do the most good for them, because I can't make her appendicitis go away, but I can at least do the things that are necessary for treatment and transport to make it maybe at least a little less miserable.
What does an appendix do for us?
Now it does nothing. When we were cave people and we used to eat a lot of raw meat before there was fire, it used to help break down some of the additional bacteria in like raw meat and the dinosaur carcass that we were eating. But that's not a thing anymore.
Flintstone, okay.
So here's another one that we can actually, with pretty good certainty, begin to at least put our finger on and figure out a little bit. Cholecystitis. The cholecyst is the gallbladder. Itis is inflammation. So what we're really talking about here is inflammation of our patient's gallbladder. Generally associated with the presence of gallstones. It occurs in a very specific age group with very specific sort of lead up to it. And what that means is the most susceptible people to this are generally women over the age of 40.
Thank you very much.
Generally, people are, let's just say, at least slightly to significantly overweight. And really, one of the big triggers for inflammation of the gallbladder, because what the gallbladder does is house bile that breaks down fat. Generally, these people have eaten some sort of high-fat meal before this pain started. Common signs and symptoms of our gallbladder or cholecystitis being a problem is generally sudden onset of right upper quadrant pain. It may radiate a little to the middle quadrants, like so across the upper right side of the abdomen. Generally, it's at night after a high-fat meal. And when we palpate that right upper quadrant, our patient's going to have some referred pain. Our patient is likely to have pain round about the right scapula when we palpate that right upper quadrant. They're going to complain of indigestion type symptoms, belching, heartburn. They may have some nausea. They may actually vomit something that is greenish looking liquid. And that really is the textbook presentation of our patient with a gallbladder issue.
And diarrhea too, right?
Yeah, it can cause some diarrhea.
I got a really bad attack like that, and I had diarrhea and throwing up, and my belly was in pain.
Yeah, it's nasty, nasty, nasty business, because that is particularly painful and difficult for folks. And surgical intervention is sometimes required, sometimes not. As far as, is this like a crazy, run screaming hell bent for leather to the emergency room type of emergency? Not all the time, but the longer it's been going on for, the more likely there is that that gallbladder will experience some tissue ischemia and some maybe even necrosis and cause a significant infection, cause significant amount of that bile to leak and irritate the entire peritoneal cavity, and make your patient that much sicker. Because all of those hollow organs and the nasty stuff that they hold inside of them, when they are no longer inside of those organs where they are protected and where they belong, they cause infection. They cause something like, I don't know, septic shock in a short order of time. Because think about what would happen if your intestines decided they were going to leak all of the waste products that build up over time that you're supposed to deposit into the toilet. Think about what would happen if your intestines just decided to let that stuff leak into your body.
They would poison your blood system.
It would poison you quick, fast, and in a hurry. You would be about as sick could be, and would wind up way into the intensive care unit. You would be on antibiotics. You would wind up with emergent surgeries. This is the kind of thing that we need to think about. So patient presentation is really important. Getting a good handle on what this patient's vital signs are, especially now. We'll talk a little bit about GI bleeding. When I mentioned that mesentery, I talked about all the blood flow, right? That means our gastrointestinal system has a almost unlimited supply of our body's blood. The gastrointestinal system is supravascular and really has the ability to cause us enough bleeding that we could bleed absolutely to death before any real problems started to show themselves. Our GI bleed patient is generally somewhere between the ages of 40 and 70. Like I said, the causes can be just about anything. It can be anything, something as simple as having a small bowel obstruction or something like that that causes the intestinal wall to break down. Or it can be someone who had a surgery, someone who has just any one of a number of things. But what we're on the lookout for is my patient presenting with loss of blood from their person? Because this is an internal bleed that will actually show itself externally. We will see or have a patient complain of hematemesis. Hematemesis is the vomiting of blood. Hematemesis means that your patient is actually throwing up blood.
Blood.
Your belly will not break down the iron in your blood, so the red blood cells won't get broken down. If your patient has hematemesis, they are throwing up what looks to be actual frank blood, is what it's called. So it looks like normal blood.
Yeah.
Hematochezia, the next thing on that list, is the throwing up of what looks like coffee ground. Oh no, sorry. This is hematochezia. I always screw these two up. Hematochezia is the passing of blood in your stool. So hematochezia is a bowel movement. Remember, we asked during the L of sample of their last ins and outs, is frank blood presenting itself in the stool. Depending on what the blood looks like when it comes out is going to depend on where the GI bleed happens to be. If your patient is vomiting frank blood, looks just like normal blood, it is a really high upper GI bleed. That's closer to the exit on the top end than the bottom end. Because when that blood gets down actually into the gastric acids of your stomach, since your stomach acid won't break down that iron, your patient will vomit something that looks like coffee grounds. It looks like it came out of the filter that I made my pot of coffee in this morning.
Mm-mm.
If my patient has hematochezia and they are passing frank blood in their stool, that means it is way close to the south end of this whole system, because it still doesn't need to get broken down. This is something a lot of the times that's, a rectum or anus type problem, maybe hemorrhoids, maybe a tear. If your patient has melena is the passage of dark, tarry, sort of sticky, weird looking stools. And that means it's further up in the abdominal tract in the intestinal system, because your body is still trying to fight and break down some of that blood. None of this is good. Not one bit of it is positive for your patient, because there's no way to tell how much blood's been lost. There's no way to tell realistically how long this bleed has been going on for. And really, some of the first things we'll see are generally some sort of altered mental status, possible weakness or a syncopal episode. So your patient will stand up too quickly and tip over and fall down. And signs and symptoms of shock. This patient will have bled enough without spilling any blood that they will actually already be in shock before they ever even call 911, before they ever even have any one bit thought about it, because all of that blood is being lost internally until we see the hematemesis, the hematochezia, or the melena causing concern. Because if your patient does any one of those three things, clearly that would be cause for concern for just about anybody. I know people that wouldn't call 911 if their life depended on it. And if they saw any one of those three things, they would be on the phone with the dispatcher in very short order. So esophageal varices are varicose veins. I don't know if any of you guys out there have heard of them. They are veins generally further away from the heart that wind up under pressure. They wind up with those spider-looking veins. They sort of bulge out. You can see them. Veins aren't typically under pressure. They're not good at that. That's not what they do. We have a bulging and engorgement of the veins in our esophagus. They're equally as bad at being under that pressure. Those esophageal varices can be caused by a couple of things specifically. One of them is unchecked hypertension. Another is a patient who has a long history of alcoholism. And what we see with these people is a ungodly amount of bright red frank blood pouring from our patient's airway. There's going to be large amounts of hematemesis, and I mean crazy amounts, stuff that you couldn't keep up with suction anyway. There's going to be almost no pain or tenderness in their abdomen. They're going to have a rapid heart rate. They'll have difficulty breathing. Now we're going to hear some skin color temperature condition, and tell me what you think about it. They're going to be pale, cool, and clammy. What does this sound like?
Shock.
What kind?
We're talking about bleeding, right? So
Yep,
hypovolemic shock.
bingo. This is hypovolemic
It's not
shock,
the only one we need.
like flicking a light switch. This patient is bleeding significantly enough that they almost immediately go into hypovolemic shock and are going to show us the signs and symptoms of shock. If a patient has esophageal varices that haven't ruptured, Some of the things that we might see on them is a change in skin color, temperature, and condition as well, but they're not going to be pale, cool, and diaphoretic. They're going to show us a sign of liver disease. And what that
Yellow.
is, yeah, jaundice. This guy's eyes will, without even being funny about it,
Will be
be this
yellow.
color. His entire body could be this color. And that tells me, without question, that this patient has some sort of advanced type liver disease. If it's esophageal varices, hopefully they don't burst and we get them to the emergency room. If it's anything else, hopefully my patient doesn't get worse and we get them to the emergency room. Your esophageal varice rupturing is going to be someone to be on the lookout for shock. We're going to have an airway problem. We're going to have a breathing problem. We're going to have a circulatory problem, and it is going to be difficult to manage. There's just no question about that. That is a profoundly ill patient because all they're going to do is get worse.
Gastrositis.
Next thing we're going to talk about here is a hernia. Hernias can be kind of god awful to look at if you really want my honest opinion on it. A hernia occurs when there is a tear in the abdominal muscle that allows a loop of bowel to actually poke out through that hole. And you'll see this great big giant bulge of what is actual abdominal contents poking out through the tear in that abdominal muscle. Your patient is generally going to have done something recently or have a history of this because they don't always fix them right away. But generally, anything that causes your patient to strain can cause that weakening, cause that opening in the abdominal muscle, and allow that loop of bowel to poke out. Most of the time, hernias aren't life-threatening. They can be easily treated. My brother-in-law used to have one that popped out all the time, and he could just push on it and make it go back in. When this becomes a real significant problem is when it becomes what's called incarcerated or strangulated. A portion of that intestine that's poking out will actually get pinched when the hole in that abdominal muscle closes. And as it's getting pinched, there's going to be an obstruction. There's going to be loss of blood flow. There's going to be ischemia. Your patient will complain of a sudden onset of abdominal pain, and it will be different than what their normal hernia pain is. They may even have a fever. Their pulse is likely to be rapid. They're going to have tenderness at the point of that hernia. So when we do our palpation around where we're pressing, around where that hernia is, it is going to be very, very painful to the touch. And now let's talk about nausea, vomiting, diarrhea. God, is this a very, very commonplace call? Most of the time, adults have enough fluid reserve in their body to overcome even a significant amount of nausea, vomiting, diarrhea. A couple of days with the flu and some nausea, vomiting, diarrhea, you're going to feel like hell, but generally, you'll do okay. When we really become concerned for nausea, vomiting, and diarrhea is persistent, multiple days of it, not able to hold anything in, and a patient who presents like they are dehydrated. So dehydration, non-hemorrhagic form of hypovolemic shock, is a long period of nausea, vomiting, diarrhea without the ability to replace any fluids. So what might this patient sort of look like?
Diaphoretic, sweaty.
Okay, keep going.
Pale from losing so much Um, vomiting, diarrhea, they're gonna look pale from so much vomiting, sweaty. If they're constipated, their belly's gonna be distended. It's gonna be protrude like full, like if it's bloated.
All right,
Um,
I'll take it. But let's talk about that sweatiness there for a minute. If they're dehydrated, are they likely to be sweating a whole bunch?
no, they look dry, like
Yeah, they're going
crusty.
to look dry. This is someone whose lips and tongue and mucous membranes look like you could light a match on them.
And their nail beds too.
Yep, they're going to be pale. They're going to be cool. They're going to be that clammy, like without actually being sweaty. They're going to be sort of just like cold and kind of gross feeling to the touch. They're going to look absolutely completely bone dry. Their eyes might even be sunken in a little bit. And most of the time, adults still can overcome this. But when we talk pediatrics and elderly, one of the things that you'll learn as we kind of work our way through all of this stuff is the two outliers of our spectrum here. People that are really young, people that are really old, do not do as well in most situations as the middle of the road. Our young patients, they don't have enough volume. They don't have enough fluid reserve. So with a child, just a few hours of nausea, vomiting, diarrhea without being able to replace any fluids is going to be problematic. We'll see those soft spots in their heads, the fontanelles, actually begin to become sunken. Our patient will look profoundly hypoperfused. They will look very, very much like a little kid who's in shock because they do not have the ability to maintain their perfusion because they've lost so much of their circulating volume. And they are very, very ill. Babies, the same thing. If a parent reports to you that their child has had nausea, vomiting, diarrhea since the morning, and then you ask them a question like the L in sample, well, when was the last time you changed a diaper? And they can't remember, that kid is sick. Period. No questions asked. That kid is sick.
Mm-hmm.
Remember, kids maintain for a really long time. They compensate right up until the bloody end. So things like that should be what starts to sort of tingle your spidey sense to make you start thinking, all right, this patient's ill. And the same goes with elderly people. Elderly people, for one reason or another, they're never thirsty, they're never hungry. We'll get into the reasons why a little bit later on in the program. And they sometimes take medicines that will actually make them slightly dehydrated anyhow. So now add to that just a few hours, maybe a day or two of constant and continuous fluid loss, and they begin to decompensate and they don't do quite as well as our patient here that we're talking about with nausea, vomiting, diarrhea. So always keep in your mind that old folks and kids generally are a bit sicker sometimes than they actually show us for real. Well, now let's talk our assessment. Just like any other assessment, we start in the exact same place. All of this stuff is done in a regimented fashion for a reason. So first things first, scene safety, BSI. With abdominal pain, we start thinking mechanism of injury versus nature of illness, because it could be one or the other or both. So start thinking, hey, is there anything that could have injured this patient that caused this? Or at least try and rule out any traumatic cause, because those are going to be different sort of bits of information. Look around the scene, talk to your patient. We're starting to form our general impression now as we're moving towards our primary assessment. As we're forming our general impression of this girl right here, tell me something you see right away. Well, let me ask you this. Do people just normally decide that they're going to lay down in the middle of the floor and hold their belly?
No, absolutely not.
All right, so what's your general impression of this patient?
She's clearly in a lot of pain.
Yeah,
Yeah, something is hurting her.
something weird is happening to this patient.
And yeah,
Haven't spoken to her, don't need to even talk to her. I look at that patient and I go, people don't do that. Because, well, people don't do that. You don't just walk across the living room and go, all right, this looks like a good spot. You know, turn around 3 times in a circle like a dog and lay down. That's just not the way that this works. You know, if she was able to, she probably would have laid on the couch. So we formed our general impression. We've gotten there. We start evaluating our ABCs. We need to ensure a patent airway. We need to make sure it is open, clear, and secure. If we find a problem with our airway, we need to fix the problem with our airway, up to and including inserting an OPA, an NPA, head tilt chin lift, jaw thrust, whatever it takes to make that airway patent. And then once we had done that, we move on to breathing. And we look at her rate, rhythm, and quality. We listen to a quick set of lung sounds just to make sure that she's moving gas and she's getting a deep enough breath to get everything down to those alveoli so that the gas exchange can take place. Because let's say on our next little bit, because we're already thinking ahead, we're starting to think signs and symptoms of shock, because we're going to verify that with our circulation check in just a minute. If we start to recognize some of these problems presenting themselves, we know that oxygenation, even if it's not a problem now, is going to be a problem. So at breathing, we apply oxygen, 15 liters per minute via non-rebreather mask, as long as we have a good rate, rhythm, and quality. Long as she is doing it adequately enough on her own, non-rebreather mask goes on. I see a hand.
My bad. I was trying to clean my screen.
Okay, no problem. After we've assessed and treated breathing, we move on to circulation. I'm going to get radial pulse on someone who's awake. I'm going to get a radial and a carotid on somebody who's unresponsive. And I'm going to compare and contrast those if I have 2 pulse points, because I want to know, do they feel the same? I'm looking for rate, rhythm, and quality of her pulse. And then I'll check her skin color, temperature, and condition. And this whole piece, all of this, with the level of consciousness, general impression, airway, breathing, circulation, is going to tell me, have I found any signs and symptoms of shock? I make my priority transport decision. What am I going to say at this point? What is this patient?
High priority.
And what am I going to do with them?
Transport them to the nearest facility.
With?
With 15 liters of non-rebreather mask, 15 liters of oxygen.
All right.
And ALS.
To bump into and meet up with on our way.
ALS.
ALS.
All right, I like it. So they're a high priority transport to the closest appropriate facility with an ALS intercept en route. And then I move on about my business and get into my secondary assessment. What's my secondary assessment? What am I going to do?
Focus physical assessment on and palpate the area of illness.
All right, so I'll palpate the abdomen. I'm going to start with the least sensitive, the least painful area, and I'll do my focused physical. What else am I going to do? We're going to say this patient is conscious.
History and OPQRST.
All right, so tell me what all that means.
Onset, what was they doing when it happened, if there's anything provokes it, the severity of their pain, the quality of their pain, the time, the last oral intake.
Do they take anything for the pain?
All right, well done. And what's the last little bit of my secondary assessment? I've done my focused physical. I've done my OPQRST. I've done my sample. What else do I need to do?
Vitals.
Yeah, I get my vital signs. I want to at least get pulse, blood pressure, respiratory rate.
Can I ask the question?
You can.
Why would my vitals be the last thing? Couldn't my vitals help me predict my secondary assessment as I'm
So
talking to them?
your primary assessment gives you, and don't be confused, because when this class is over and you guys are out third riding on ambulances and you're out actually providing service in the field,
The vitals come first.
everything's a bit different because there's two people. Right
Okay.
now, you guys are being evaluated on your ability to actually perform these skills. So you're all by yourself.
Okay.
That's why we do things in class in the order that we do, because
Okay.
you have to assess the patient for the vitals to actually mean anything, and then for the treatment to be able to be administered. Out in the field, this stuff happens a whole lot faster. It happens a whole bunch differently, but all the same pieces are still put together.
So this is just so we can learn to get like a rhythm of it
Yep,
for our actual state where we sit in front of somebody.
you got it. Remember,
Okay.
crawl before you walk, walk before you run, run
That's
before
why
you.
or second to last, because after our vitals, then we have to verbalize our interventions.
You got it. And for
Okay.
our interventions for an abdominal pain patient, what do you think we're going to do?
High flow oxygen, and transport them to their nearest facility as soon as possible, because I
We're going
don't
to,
see them have anything to give them.
not one thing. We're going to monitor for signs and symptoms of shock. We're going to reassess our patient every 3 to 5 minutes, and we're just going to do what we can to keep them comfortable. However we have to do that, we can accomplish it. If it's laying on their side with their knees tucked up, you can still buckle them on the stretcher appropriately and get them transported and have them be as least uncomfortable as possible.
So is it fair to say that when we're talking to our test person, our chief, when we have something like this, we need to state that we're monitoring for signs and symptoms of shock because they're having a gastric episode and there's not really much we can do for them, but keep them comfortable on the route to the appropriate facility.
Yep. What
Okay.
I'll tell you about your impending state exam is you aren't going to get something that you can't treat. So
Oh,
it's going to be something that you have a treatment for.
so
Now,
cardiac.
whether or not
Mhm.
you can actually provide that treatment is going to be based on how well you know your protocols and what needs to be done to appropriately treat the patient.
Okay.
All right.
Fair.
Before we move on to our genitourinary, we're going to take a short break, and we will come back, finish out this lecture, and get rolling on the other two.
We break for 10 minutes?
Yes, we will.
Okay.
Okay, we're back. We're going to cruise through the last little bit of this and talk about genitourinary and renal emergencies. We're going to talk structure and function here for just a little bit. Our kidneys, we went over yesterday what it is that they are meant to do. Somebody please refresh my memory. I must have forgotten.
Filter
What's about the blood?
unusable material from
Bingo,
blood.
bingo. Both of you are correct. Their job is to filter out the waste products and to create urine. The kidneys, when they're done filtering out all of our blood and getting all those waste products out, they pass urine down through those ureters and they wind up in the urinary bladder, where sooner rather than later it is excreted from the body and life goes on. This is when all of these things are functioning appropriately. The kidneys filter things out the way that they're supposed to. The ureters are functional and passing that urine down into the bladder. The bladder holds on to that urine for a little bit. And once it's full, off it goes on its merry way down into the flush zone. As far as what we have for problems with our genitourinary system, they are both, as far as structure and function goes, relatively close to the same between male and female patients. We wind up with a lot of the same problems. We wind up with a lot of the same issues. One of the ones that we'll talk about here is a urinary tract infection, an infection in the actual urinary tract from the outside to the inside. So this is something that begins in the urethra. The longer that this urinary tract infection goes on unchecked, it can travel backwards from the urethra up into the bladder and even into the ureters and kidneys. It can have a profound effect on your patient's ability to actually excrete waste from their body. Because when that urinary tract becomes infected and inflamed, it shrinks down and it makes it almost impossible / at least very difficult for your patient to really empty their bladder. These things are easily treated. All it takes is a quick course of antibiotics and your patient generally does just fine. But now we'll get into our outlier people again, the elderly. When an elderly person develops a urinary tract infection, it can become raging out of control in no time flat, and we wind up with an elderly person who's acutely altered and showing us signs and symptoms of septic shock. They're likely to be warm or hot to the touch, or ice cold, depending on how sick they are. They're likely to be tachycardic and hypotensive. And sudden onset altered mental status with a source of infection, as far as an elderly patient goes, is like textbook for septic shock, especially when we start to see some of those other signs and symptoms. And urinary tract infections are a great big giant contributor to that actually happening. Next, we have kidney stones, or what's known as renal calculi. These are calcium stone-like structures that build up inside of our patient's kidneys. And when they stay put, they're not altogether that awful. Once those renal calculi start to move around and start to progress their way into the smaller structures of the kidneys and the smaller bits of our patient's ureters and urethra, this is, 20 out of 10 pain. This is a patient whose hallmark sign and symptom is going to be intractable or unable to relieve flank pain on like the side back of their rib cage. So more posterior, but like the side of their rib cage. These renal calculi look like tiny little spiky balls on the microscope. It is just going around and shredding and causing a whole bunch of pain, could cause some actual bleeding when your patient urinates, and they are just obscenely painful. But on top of being a whole lot of pain, they can also cause damage and cause a whole bunch of complications if they wind up blocking the kidney or blocking the ureter. Kidneys don't handle stuff like that very well, and it could be entirely possible to actually lose function in that kidney that's been blocked off by a kidney stone. Your patient who is having this type of pain, on top of just being very, very uncomfortable, is also really in the process of having a true medical emergency until proven otherwise. Because without functioning kidneys and having something like kidney failure, you in very short order will either wind up on renal dialysis, which we'll talk about briefly here in a couple minutes, and that'll be the end of things for this lecture, or dead. Because if your kidneys stop functioning and that problem is not corrected, all of these waste products will build up in your body and your patient will die. When we talk about kidney failure, we have a couple of things. It can either be an acute renal failure, or it's abbreviated ARF, or chronic renal failure, which is CRF. Acute renal failure will have some generally reversible causes that can be fixed, that can be managed and maintained so that those kidneys will still begin to function. Things like a traumatic event that leads to hypovolemic shock, sepsis, UTI, generally those kind of things can be reversed, and our acute renal failure patient, once their problem is handled and managed and worked out, they go on about life, never needing any further intervention as far as that goes. Our chronic renal failure patients, on the other hand, are what are known as end-stage renal disease. End stage is just what it sounds like. It is permanent and life-altering at best, and generally is part of whatever causes these patients to pass away. You require either a kidney transplant or dialysis. Dialysis is a process where your blood is actually pumped out of you through a machine that removes all of those waste products, pumps your blood back in, and it continues to go round and round. Dialysis patients are some of the sickest you will ever see on an ambulance. They have multiple problems and multiple ways that they can decline. On top of filtering out your blood and creating urine, your kidneys will also make it so that we don't wind up fluid overloaded and have way too much fluid floating around in us and cause some of that, pulmonary edema and heart failure and swelling in our lower extremities. When your kidneys aren't working and aren't doing their thing, you will produce much less urine. Some of our chronic renal failure patients will produce almost none. And without dialysis, they will eventually have all sorts of metabolic problems. They will all have all sorts of cardiac problems. And generally within about a week or 10 days without dialysis, a chronic renal failure patient passes away. Dialysis is a process that happens every other day, generally either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday for these patients. They spend somewhere between 3 and 4 hours hooked up to this machine, and it is just so that this external machine can function almost like their kidney and get their blood cleaned out and get things moving round and round the way that they're supposed to. Dialysis is going to restore our fluid balance and our electrolytes. Electrolytes are very important for the conduction of nerve impulses, for controlling your heart rate and rhythm. So if these electrolytes get all out of whack, our patient is going to have large amounts of problems. They correct acid-base problems in your patient. If your blood becomes too acidic, oxygen can't move anywhere. It can't get out of the alveoli. It can't get out of the bloodstream. The cells wind up hypoxic. Our patient winds up hypoperfused, and on go the problems. They just get bigger and bigger and bigger and bigger and bigger. These are the patients that we see most often. Dialysis companies, whether it is DaVita or the other one's name escapes me at the moment, but they are Forbes 100 companies. They are hugely profitable. This is an expensive process. It is a life-altering process for our patient, but it is also a life-saving process for our patient. Now, the way this hemodialysis takes place is generally in the very beginning, our patient will have an IV catheter surgically implanted in their chest that this machine hooks up to and moves blood into this machine, circulates it around, gets it all scrubbed clean, and puts it back. Down the road from there, doctors will actually go in and perform a surgery to put in an AV fistula, which is where they go into the patient's arm. Generally, they're non-dominant, so most of our patients will have a fistula in their left arm because 70% of people are right-handed, and they sew an artery and a vein together. And in doing that, they create a spot. You can see it right here on this woman's arm, where needles are inserted into this AV fistula, and blood is pumped out and blood is pumped back in once it gets through the other side of this machine. This AV fistula is this patient's lifeline. One of the things you always need to look out for, especially if you know your patient is a dialysis patient, is we cannot take a blood pressure on the side of the patient that this AV fistula is in. Because if we do, we will crush that surgeon's hard work, and the patient will no longer be able to use that fistula, and they will go into acute renal failure because they can't receive their dialysis anymore. And a lot of very negative processes will happen to that patient from there on out. So how do you know they have an AV fistula? Well, first you will see on their arm this great big lump looking thing that almost looks like mushrooms growing on a stump. It looks very non-anatomic. And if you were to touch it, you'll feel almost like this vibration in your fingers, because the blood flow is very, very turbulent and very, very unhappy in that area. And you can actually feel, it's called a thrill. You can feel that little bit of vibration. And you'll see needle marks from where these needles are placed over and over and over and over and over again. And you know that that is an arm to stay away from. One of the things with these dialysis fistulas is they are very, very prone to bleeding. And when they do decide that they're going to let go and bleed, it is under pressure 100% of the time. And this blood sprays like you would not believe, like a hose. And this is what it looks like on a person. You see all of these sort of strange looking things you have here, and it almost looks like there's a hose running under this patient's skin. That is this patient's lifeline to the world. This is their mature hemodialysis fistula. This is how they receive their treatment, and that is what keeps them alive. Now, all the rules of hemorrhage control, which we'll talk about when we get into the trauma lectures, apply. If this fistula is spraying the room with blood, well, the fact that they won't be able to receive their dialysis if I crush this is kind of out of the question, because they'll bleed to death right in front of me instead. So we will do direct pressure. We will do tourniquets if we have to. There's some other sort of off the record type things that I've done previously to make these things stop bleeding. Figure that out on your own, because I don't like getting myself in trouble. But there are ways to make this stop bleeding when it's bleeding. And we have to make it stop. But not taking a blood pressure and being very, very careful with your patient who is a dialysis patient is going to be the name of the game, because these folks are susceptible to all sorts of medical complications, all sorts of medical problems, and they really are quite sick. Anybody have any questions on that topic?
What about graft connection?
Sorry, what about what?
Graft when for a dialysis patient.
So the grafts and the fistula, we're going to treat pretty much all the same. It depends on what kind of surgery they do and what sort of work underneath the hood that they do. To me, as a field provider and as an educator, it makes not one bit of difference, and it really doesn't to you guys either. They have all the same sort of bits of trickery. They can be very, very leaky. They can be very, very dangerous to the patient. It's possible route of infection because they're constantly getting poked with needles. It is something that patients, most of the time, since they know how important it is, they will tell you, like, you cannot take a blood pressure on that arm. Even if you didn't find it, they'll let you know. Anybody else?
On assessing these patients, so if Cataldo, like we have to do a transfer to from somebody's house to get their dialysis, that's
Mhm.
something that we assessed, right? To make sure that it's okay and it's not infected or anything like that.
Sure. And most of the time, these dialysis patients are closely followed, and really, as much as I'll sit here and tell you until the end of time that they are very, very sick, they don't oftentimes require a lot of intervention from us because they see a nurse and a doctor and all sorts of people 3 times a week. Like, there's no option for them. So they are constantly being evaluated. Somebody is constantly looking at this. So
Okay.
as far as
That's what
that
I mean.
goes,
We're not gonna get a patient with one of these things. Oh my God, like they're in you know what I mean? All affected and whatnot.
if we do, most of the time it's going to be picking them up from the dialysis clinic and bringing them to the emergency room. It's not
Okay,
necessarily generally the other way around. It can be.
noted. All right, thank you. That was my question.
All right, good deal. All right, so let's move on to endocrine emergencies. One of the things that we're going to talk about, and realistically the only thing we're going to talk about with endocrine emergencies, is diabetes. The actual clinical name for diabetes is diabetes mellitus. And what this is a problem with your body being able to use the sugar that it intakes. Sugar, when we get right down to the cellular level, glucose is what is going to provide our cells the energy they need. Glucose is it. The brain cells use only glucose and nothing else. They don't store it. And without an adequate amount of sugar being introduced into those brain cells, one of the main things that we'll talk about with diabetes is altered mental status. And it can be anything from a patient who is behaving like an absolute raving madman, or someone who is completely and totally as unresponsive could get, and anything in the middle. Yesterday, when we talked about altered mental status, I said, it's very difficult to nail down all of the things with altered mental status, but diabetes is something that we can take a look at and we can figure out, does this patient have a problem with their blood sugar? I take a quick finger stick. It takes no more than about 10 or 15 seconds, and it will tell me, is this patient's blood sugar low? Is this patient's blood sugar high? Or is this patient's blood sugar just right? So I have crossed off one of the causes of their altered mental status if I find blood pressure that's just right. And really, we have to make sure when we're assessing an altered mental status patient that we make sure we cross off all of the things we can before we just make the all too easy decision of, oh, well, this patient is just a behavioral, or this patient is just using, or this patient is just drunk. We have to make sure we've crossed off head injury, we've crossed off diabetes, we've crossed off hypoxia, we've crossed off any one of a number of other things that we can take a look at, stroke, seizure, and make sure that we have dotted all our I's and crossed all our T's before we throw up our hands and go, well, I guess there's just something wrong with this patient's mental status. Diabetes is about the easiest to figure out. So, normal body process on the left, diabetic patient on the right. On the left, your body ingests. We take some food in, we turn it into digestive processes, and it goes down into the stomach. The stomach begins to break down that food. Food gets passed on into the small intestine, and it gets turned and broken down into simple sugars. And the mesentery that's around that GI system picks up those simple sugars and puts them out into circulation. Now, the way a healthy patient's body works is, at that moment in time, the pancreas, right here, this little yellow, weird looking upside down Nike swoosh thing is your pancreas. It's in the right upper / both upper quadrants of your abdominal cavity. Will release some insulin. Insulin is what maintains a healthy blood sugar level. Insulin is actually what allows that sugar to get into the cell to create energy. At a microscopic level, the sugar molecule is very big, cells are very small. Without an appropriate amount of insulin inside your patient and being released from their pancreas to help this sugar actually get through that cell wall, all the sugar in the world is not going to help this patient because they don't have any insulin to turn the lock and open up the door so that sugar can go in. That's what insulin does. Our diabetic patient, whether it's a type 1 diabetic or a type 2 diabetic, we'll talk about those in just a minute, either doesn't produce enough insulin, doesn't produce any insulin, or their body doesn't use the insulin effectively. Type 1 diabetics, their body has given up producing insulin altogether. So our diabetic patient will eat some food, same, digestion begins, food is broken down into simple sugars, passes through the small intestine, the mesentery picks up all of that simple sugar and puts it out into the bloodstream, and the pancreas goes, nah, not today, and doesn't release any insulin. So we get down a little bit further and we see that since no insulin has been released, that sugar can't get into the cell. Some of that sugar gets eliminated in the urine. A lot of that sugar just maintains in the bloodstream, and the cells aren't getting any of it. So you want to know what message those cells send off? Hey, we're starving down here. You need to feed us. We don't have enough sugar. So your diabetic patient eats again, and digestion begins. And food is broken down into simple sugars in the small intestine. And those sugars enter into the bloodstream, and the pancreas releases little to no insulin. And the sugar can't get into the cells. And if the sugar can't get into the cells send off that exact same message. Hey, we're starving down here. Feed us. So that sugar just floats around in your patient's bloodstream, but the cells aren't getting any of it. So food is eaten and digestion begins. And you'll watch a patient, their blood sugar will go and step up and step up and step up and step up. And it just goes up and up and up and up and up with absolutely no relief. And the cells are not getting any of that sugar. So they're not producing any aerobic metabolism. And if they're not producing any aerobic metabolism, they switch to anaerobic metabolism. Your diabetic patient becomes very acidic and eventually winds up with an altered mental status, unresponsive, and very close to being dead because their sugar just keeps going up and up and up until it can't go up anymore. Hyperglycemia is a problem that takes time to develop. Hyperglycemia, generally your patient and their family or whoever you're speaking with is going to tell you, I felt like crap for a little bit of time. It's not going to be, well, 1 minute I was fine and the next minute I was unresponsive on the floor. Your hyperglycemia patient, it's a more prolonged onset. Hyper meaning high, glyce meaning sugar, emia in the blood. Your hypoglycemia patient, on the other hand, we'll get into the mechanism of all of that in just a minute, but your hypoglycemia patient generally has a much more sudden onset. The signs and symptoms can be very, very similar, but it's how the problem actually starts that really kind of lets us know, even before we take a finger stick, which side of it are we on. So our body has a couple of fail-safe mechanisms in this whole thing, because not all of the sugar that we intake and not all of that simple sugar that gets broken down is used. Some of it gets stored for times when maybe there's not food available, or you get that you wind up having to skip lunch and you get sort of that middle of the afternoon burst of energy, and then all of a sudden you're exhausted because you've you've blown through your sugar reserves. Your body will produce a substance that is long bits of sugar, and it stores them in the liver. It converts glucagon into glycogen, and it gets stored in the liver. And that is meant for times where there's not enough sugar being intake, but the body still needs to function. So when your blood sugar goes down, even as a healthy person without diabetes, will send off some messages from the brain that will say, hey, break down that stored sugar, and that glycogen stores will break down and glucose will be released into the body, and that sugar will get into the cells, and those cells will create energy, and that's how you skip lunch but get your mid-afternoon blast of energy. But it's only a very short amount of time, because that stuff is your body's last line of defense against hypoglycemia. So when you eat something, then it goes down into your stomach, starts to get broken down, the small intestine breaks it down further, turns it into simple sugars. Those simple sugars get out into the bloodstream, and out to the cells they go, energy is created, and your body continues to function. That is the normal metabolism of sugar 101. You eat a meal, your blood sugar goes up. When your blood sugar goes up, your body secretes insulin. When that insulin gets secreted, the cells get fed, the sugar goes in, the liver creates glycogen, stores it, and holds it for later. Sooner or later, it's almost dinner time, and your blood sugar will go down. Glucagon gets secreted. All those glycogen stores break up and go out into the bloodstream to produce glucose. Your blood glucose will go up for a period of time, and then soon enough, it's time to feed the machine again, and you'll eat a meal. And this is exactly how it works on someone who is able to control their sugar physiologically. Their body just does the things that it's supposed to. Your diabetic patient, we cross this part off. So you eat a meal, blood sugar goes up. We get no insulin, so the cells don't get fed. So the blood sugar never goes down. Glucagon's not secreted. This doesn't happen because the blood sugar's up. Blood glucose is not maintained, but the cells aren't getting the food. They're not creating ATP. So they say, hey, we're hungry. So we eat meal number 2, and my blood sugar goes up again. And then insulin's not secreted, and those cells don't get fed, and the blood sugar doesn't go down, and glucagon doesn't get secreted, and this doesn't happen, and this doesn't happen, and this doesn't happen. So we eat a third time, and up goes the blood sugar. And it just continues to progress like that, just like a set of stairs, which is exactly why hyperglycemia takes a bit longer to actually progress and turn into a problem for our patient. We'll go over how to do this when you get in a little bit later on today. We'll use the glucose monitor. Everybody gets a finger stick. So here's where we get into what these actual problems are. Very simply put, we know what the primary problem is, and we have 2 different types of it. A type 1 diabetic is what used to be called an insulin-dependent diabetic. This was a patient whose body created and secreted no insulin whatsoever. So they had to take it by injection. They've come up with insulin inhalers. I personally use an insulin pump. Whatever the case may be, they had to somehow get synthetic insulin into their person because their body no longer created it. A type 2 diabetic has a couple of different causes. One of them can be just generally being unhealthy. Patients who are significantly overweight and caloric intake can way outdistance the amount of insulin their pancreas is able to produce. So they eat too much and their pancreas can't keep up with demand, and they wind up with type 2 diabetes. The other side of that is sometimes a lot of your organs are sort of on a factory warranty. It is possible to outlive the life expectancy of your pancreas and wind up with type 2 diabetes. Your pancreas starts to get old and tires out and doesn't produce insulin as much. So when you eat, your blood sugar goes up, but it's not as easily maintained because the pancreas can't hold up 100% of its part of the deal. And then the last way type 2 diabetes can be an effect on someone is their body, for one reason or another, just isn't effectively using the insulin that's created enough. Type 2 diabetes is generally controlled with either oral medications or diet. And it can also, they have come up with some new injectable type medicines that aren't technically really insulin, but they also aren't oral meds that the patient takes. So now let's talk about our acute emergencies. Hypoglycemia and hyperglycemia are two of the big ones. Hypoglycemia occurs when our patient's blood sugar falls below what is considered normal. Somebody from their protocol sheet, tell me, when do we begin treating a patient for hypoglycemia? What's my number?
Under 60?
Nah, a little higher.
120.
70?
So who had it? 70 is the number.
Oh, it's 70. Under
Below
70
and
for low.
below 70 and symptomatic. That's when we're going to actually consider treating this patient for their hypoglycemia. I say consider because the administration of oral glucose comes with a couple of caveats. Our patient needs to be able to speak to us, they need to be able to follow instructions, and they need to be able to protect their own airway. The glucose tube that we're going to help them with and administer to them and tell them to squirt into the space between their cheek and gums will create an absolute airway maintenance nightmare if my patient can't follow my instruction and protect their own airway, because it's like this sticky, almost like pasty type of thing that will get down into their airway if the patient can't maintain it and be stuck there forever and cause an airway obstruction. So there's our treatment. What do we mean when we say symptomatic? What is generally the symptom? What is generally the things that we are going to be looking for or be told for our patient who's hypoglycemic?
Cold, clammy. They're gonna act like if they're altered mental status. Sometimes they will appear like if they're drunk or something, but they're not.
The cells of the brain will not work without an adequate supply of sugar. So our hypoglycemic patient and our hyperglycemic patient, that's why they present close to the same. They present very, very similar, except for the onset and except for one other thing we're going to talk about with our hyperglycemia patient in just a minute. Our hypoglycemia patient is generally going to be altered, maybe unresponsive. Generally, I will speak from personal experience of myself and my brother, who also happens to be a type 1 diabetic, very uncooperative. So acting sort of out of character. And you're right, sweaty, clammy, anything that is controlled by the brain is tending to malfunction a little bit when your patient is hypoglycemic. So they are going to be altered. They may present as looking like they're under the influence, and they can be just nasty, nasty. But then the minute you wake them up and give them some sugar and they start feeling better and their brain is processing things again, I have personally had this happen to me. I've looked around the room and saw people that I actually knew who had responded to my parents' living room who were mad at me, and I couldn't even figure out why they were there. they explained to me afterwards with some very unkind words, but it happens. I was being a jerk because my blood sugar was like 20.
Oh my
It was not
goodness.
hurrah. Generally, we want to know why this happened when we're talking about hypoglycemia. And again, speaking from experience, I can tell you exactly why my blood sugar goes low. Maybe I skipped a meal. Maybe I took too much insulin. Maybe I was sitting down to eat a meal, or I ate my meal and I took my insulin and then I got sick shortly afterwards. It is any one of a number of things. It just means too much insulin, not enough sugar. Period. One of the things that your body does, and part of the reason that your diabetic patient may act like a raving lunatic and have like superhuman strength, is all of these things going on trigger an epinephrine release and trigger the fight or flight response. So they are an adrenaline crazed person, sweating profusely, tremulous, so they're shaky. Weakness sometimes, but not weakness like you would think of, just unsteadiness more than that. Hunger, tachycardia, dizzy, pale, cool, clammy skin. But they're going to complain of being like sweltering hot because their body is malfunctioning on a huge, huge level. The brain's not working, the body's not working. The only thing that is working is that epinephrine, and we need to get on about finishing this. So how do we treat it?
We give them sugar.
We give them sugar. Now,
Again, baja
go ahead. What you gonna say? Oh, all right. So here is the way we're going to be administering our oral glucose. The one thing I really immensely dislike about this picture is I sit here and harp over and over and over again about how my patient needs to be able to follow my instructions. My patient needs to be able to be lucid and a person in their own care, and they need to protect their own airway. And then the picture that I'm showing you is an EMT giving sugar to somebody who looks like they are out in space and actually squirting it into the patient's mouth. What would be a better decision here?
having the patient do it themselves.
Damn right. Because if my patient isn't conscious, alert, and oriented enough to take that tube from me and follow my instructions on how to administer it themselves, I have absolutely no business putting this in the patient's mouth. One of the big
No,
things
they're
I
on the
stress,
biting you.
well, she's not going to bite him because he's got the tube in the way. If she tries to bite, he just pushes forward, and that problem is self-correcting. But one of the big things I always stress during this lecture is we do not want the patient to eat this sugar. We want it to sit in the side of their mouth and melt. The buccal administration of meds is almost as fast as IV administration. And if that patient takes that tube and squirts it into her mouth and just swallows it, it's going to go down into the stomach. And the stomach actually needs to spend glucose to create the energy to break down that sugar, to turn it into sugar again, to have it get out to the cells. So we've taken a problem that was already a body that didn't have enough sugar, and the sugar that we introduced to it now is costing sugar to create sugar. So we have a net gain of almost nothing. So if
Wow.
we take that tube and have the patient squirt it between their cheek and gums and do this appropriately, it doesn't have to get into the stomach. It doesn't have to be broken down, and it is free of charge. It doesn't cost any energy at all to make this happen. So it just happens. So carefully instruct your patients on the correct way to administer this to themselves. And don't do this. Give it to your patient, let your patient do it. Because I like to work smarter, not harder. And if I'm squirting this into my patient's mouth and she aspirates on it, then I have an airway problem, and I have a patient problem, and I have a big problem.
No. Z, come on.
So that's our responsive patient. What are we going to do for an unresponsive patient? Patient's unresponsive, can't swallow, can't follow my commands. What on earth am I going to do? Because I can't do this.
There's nothing you can do.
I wouldn't say that. There's always something you can do.
Could we try No, we can't try epi.
Nope. It's not a medicine.
We try to wake them up and try to get them to drink some. Personally, try to get them to suck on a lollipop or something.
Just give them
So that
oxygen.
sugar underneath their tongue.
So nothing by mouth. If your patient doesn't meet the criteria for oral glucose, they get nothing by mouth, period. But let's think of some things that we always need to make sure that we're monitoring and maintaining and making sure that our patient goes on about their day once we're finished fixing them as a normal functional human. What can we do? Do we just find them unresponsive and throw up our hands and go, oh, well?
Monitor their airway.
All right, I like where you started. Monitor their airway. Make sure it remains as open, clear, and secure as it can. Ensure adequate respiration and ventilation. So provide oxygen. If they're not breathing adequately enough, we provide positive pressure ventilations with a BVM. We're going to assess and treat any problems we find with circulation, because soon enough, this is going to turn into a hypoperfusion problem of metabolic creation. And this is a patient we transport rapidly. And this is also a patient we would love to have a paramedic with, because they'll start an IV and give this patient sugar through the IV and wake them up like throwing a light switch. I've been that patient before. It happens fast. So think about what you have going on in front of you. Think about what the root cause of your problem is. Know the things that you can fix and maintain to keep your patient alive, and get on about the business of transporting. We're a moving company. We move people from place A to place B and back again. And this is one of those times where getting this patient moved, getting this patient to the ambulance, getting this patient in front of a paramedic, a nurse, a doctor, someone can make a pretty significant impact on turning them around and making them better very, very quickly. But we have to keep them alive, because their brain's not doing it, their body's not doing it. You have to. So when we talk hyperglycemia, we've already gone over the fact that it takes some time to build up, and it isn't something that happens quite as rapidly as my hypoglycemia patient. What we're going to talk about next is our diabetic patient with hyperglycemia, quite honestly, probably likely to have an altered mental status. Their body is not producing or is not using the insulin that it's creating or not creating, as the case may be. And their blood sugar is getting very, very high. And they turn into a patient in diabetic ketoacidosis. So this is a patient whose blood sugar is probably over 500, may not even register on your machine. It may just come up with the word high. And it is a result of their diabetes being out of control. And what is happening inside the body is just what I've already told you. Your patient is eating something. Blood sugar goes up, no insulin. Cells don't get fed. Cells don't get fed. They go, hey, we're starving down here. Feed us. Patient eats. Blood sugar goes up. Insulin doesn't get secreted. Cells don't get fed. Hey, we're starving down here. Feed us. And that blood sugar just continues to rise and rise and rise and rise and rise. And eventually, your diabetic patient's body starts to break down fat to create the energy that it needs. And it produces a substance called ketones. Ketones support that anaerobic metabolism, and they turn our patient unbelievably acidic. And that acid builds up, and your patient is going to do some things to try and get rid of some of that acid. But generally, the higher your patient's blood sugar gets, we can look out for some very specific things for our patient with a obscenely high blood pressure. First of all, we're going to be on the lookout for a patient who
Is that blood pressure or high sugar?
high sugar. We're going to be on the lookout for a patient who is peeing a lot, drinking a lot, and eating everything in sight. Because all of that excess sugar, well, a lot of that excess sugar is being excreted in the form of urine. And that urine, especially when it's loaded with sugar, is pulling a lot of fluid with it. So they are just going to be like a leaky faucet. They are just going to be peeing all the time. So if they're peeing all the time, they're going to be thirsty all the time to replace all of those fluids. And their family or the patient, if they're still responsive, may actually tell you about, just an unbelievable increase in the amount of fluid that this patient has been taking in over the last day or so. And then the hungry all the time. Why are they going to be hungry?
Because
Because
then
none
I
of their
get
cells are getting glucose.
There you go. The cells aren't getting glucose. So if the cells aren't getting fed, they're constantly sending off that message. Hey, feed us. We need some glucose. We need some glucose. And the brain goes, all right, glucose on the way. And in goes the food. So this patient will be like insatiably hungry, eating everything in sight. And then we have one very big hallmark symptom to be on the lookout for. Because your patient who has diabetic ketoacidosis generally has a fruity, almost chemical type smell to their person and to their breath. It almost smells like if you made fruit punch with nail polish remover.
like they chewing on juicy fruit.
Yeah, but it's got a much more chemical flavor than that too. And it is the body trying to breathe out all of that extra acid, trying to breathe away all of those extra just bits of byproduct that are really killing this patient. And I say the word killing because it's happening. If your patient happens to be unresponsive or barely responsive, you're likely to see what's known as Kussmaul's respirations. And this is a question the registry loves to ask. Kussmaul's respirations are these very rapid, very deep respirations, and it is your patient's body trying to eliminate as much acidic byproduct as it can. They are trying to blow off all of that acid. Sometimes your patient will complain of some muscle cramps because they're peeing out all their excess fluid. Generally, they'll complain of abdominal pain, sort of a yes and no situation. But as opposed to being that pale, cool diaphoretic of our hypoglycemia patient, this patient is going to be warm, dry, and flushed. They're going to be warm and dry and flushed because they are just losing fluid faster than they could ever hope to maintain it, and they're acidic. Your treatment for DKA or hyperglycemia of any flavor is transport. Insulin is one of the most dangerous drugs you could ever put your hands on. So giving this in the field is absolutely out of the question, because you can, in very short order, kill somebody with insulin. No problem. I just picked up an insulin prescription. I have enough insulin in my refrigerator to kill the city of Malden. So this is not something we're going to be giving in the field. This patient needs an intensive care unit bed. That's what they need, because nothing is going to correct this problem. So identifying the problem, treating your airway, breathing, circulation compromise, and getting on about the business of moving this patient to the emergency room is where it's at.
Say the patient knows what's going on. He has his own insulin. And he wants to take it. Can we stop him? Because obviously we can't give it to him. We'll help him with it.
You can't help them, but you can't stop them either. If the patient is intent on taking their insulin, and really a patient who is on insulin and knows that they're a diabetic is probably going to want to treat this themselves. But our job is to, especially like my blood sugar has lately been very well controlled. If I all of a sudden had days where my blood sugar was, 340, 350, 380, 400, 500, something is wrong with me, right? It's not just, well, we'll figure it out. No, your patient whose blood sugar isn't normally this high would feel awful when their blood sugar was this high. So try to talk them out of treating it and going to get evaluated by saying, hey, you said your blood sugar is normally pretty decently controlled anyhow. Something else has to be going on here. Maybe we should just bring you to the emergency room just for a quick checkup to make sure that, you're not really sick. But at the end of the day, if they're going to take their insulin, they're going to take their insulin, and there's not one thing you can do about it. So type 1 diabetics are more susceptible to diabetic ketoacidosis. Type 2 diabetics get this mouthful of things as opposed to diabetic ketoacidosis. Type 2 diabetics generally wind up with hyperglycemic, hyperosmolar, non-ketotic syndrome. I cannot say that word without reading it slow to save my blessed life. Hyperglycemic, hyperosmolar, non-ketotic syndrome. It is nearly identical to diabetic ketoacidosis, except they don't produce those ketones. They don't produce that fruity, acidic smell. Their blood sugar is every bit as high. They are having every bit as much of a humongous problem. And everything is still just as bad inside this patient. They're just not likely to have some of the more easily figured out. And your assessment's going to tell you that they are a type 2 diabetic as opposed to a type 1 diabetic. So onset and skin signs and what the machine is actually telling you when you're going to try and assess and figure out what is wrong with your diabetic patient is where it's at. How quickly did this problem start? Are they pale, cool, diaphoretic, or are they warm, dry, and flushed? And what number does that machine give me is going to tell you hyperglycemia versus hypoglycemia. Okay, folks, we are back and live and after it. Excuse me, Chapter 22, Psychiatric Emergencies. Some of the things we need to talk about are some things that we have already mentioned. Before we just label something as a behavioral crisis or a psychiatric emergency, we have to understand that it can be acute medically caused, it could be an actual mental illness, it could be drug or alcohol related, it could be stress related. Everybody has a breaking point, and sometimes when enough stress gets heaped onto a person, they may not have any actual really diagnosed mental illness, but they may have some form of behavioral crisis that brings us to them. So most of the time, everybody does have some form of emotional crisis, behavioral crisis. That doesn't necessarily mean that everyone is going to develop mental illness. Don't start jumping to conclusions about your patient and making generalizations as far as, oh, they're just crazy, or maybe, oh, I'm just crazy. Your body builds in these defense mechanisms to get you to the help and assistance that you need and does the same for your patient. It doesn't necessarily mean that there's anything wrong with you or your patient. A lot of these behavioral mental illness type calls, really, by the time we get there, we're not providing a whole lot of medical care for our behavioral patient. We're not providing a whole lot of medical care for our mentally ill patient. You know what most of these patients benefit the most from?
Talking and listening.
Talking, yeah. Some of that actual interpersonal communication that just lets them know that, hey, they're being heard. Because 99 times out of 100, I will tell you, you are not going to be able to fix their problem. You are not going to be able to get them out of the fact that they've recently had a divorce or lost a job or had the death of a friend or close relative or any of those things. You are not going to be able to change the fact that they have depression, bipolar disorder, schizophrenia, anxiety, you name it. You can't fix that. But once these folks feel like the people that are providing care to them are actually listening to and paying attention to the words that are coming out of them, it takes a bit of the ramped up nature off of this call. Now, that's not always. We're not going to get a whole bunch into the assessment and treatment of these folks here in lecture or really at all, because most of the time we are very, very limited as far as all that goes. And do they all go that smooth where you can just sit down next to your patient in the ambulance and talk to them on the way to the emergency room and hopefully just lend sort of a kind and compassionate ear to them and actually pay attention to the things that they're telling you? No, that doesn't always work. Nothing always works. One of the big things we need to keep in mind is scene safety. If your patient is aggravated to the point or mentally ill to the point where they are a danger to themselves, they are also a danger to you. So keep in mind that there are times where we will get called out on what is termed around here as the EDP, or the emotionally disturbed person. And we may have to transport with police on board. We may have to actually restrain a patient. But very, very infrequently, I have never had to physically restrain a patient, because it's all in how you approach the person more often than not. It's all in the way that you carry yourself during the commission of doing your job. And that's something that we will really learn about along the way. It's kind of, the learning curve of actually going out and providing service as an EMT. But what is the actual textbook definition of a behavioral crisis? It is behavior that you can see from a person that is deemed aberrant by societal standards. So it is someone who is acting out of character, acting out of sort of what society and the people around them and even them themselves would deem as typically acceptable behavior. Stress is a great contributor. You add stress and drugs and alcohol to someone who already has some form of diagnosed mental condition, all of these things are like the perfect storm of a developing behavioral crisis and a psychiatric emergency. How do we generally wind up there? Well, somebody calls 911 as a result of this behavioral emergency. Don't be surprised when you show up if a patient presents as agitated or uncooperative or any of the other things that a patient can be that is going to make our job more difficult. Okay, fine. That's how they're reacting to the situation. But you showing up has now affected a change in that situation. Unless we are currently witnessing a fight happening, all of the things that happened before we got there are pretty much null and void. Approach this patient like you would any other patient. Form your general impression. Verify that all of the ABCs are in order, and then get on about the business of assessing this patient. What their actual mental disorder or behavioral crisis is is wholly immaterial to me. I am not a psychiatrist. I am not a psychologist. I am not a clinical social worker. What I am is someone who wants to make sure that your complaint is being addressed. So you show up and treat this patient like you would treat any other patient. And you can actually, a lot of the times, watch some of this violent nature and agitation and uncooperative sort of melt away.
No, you're gonna eat a waffle.
Not everybody who shows up on these calls all the time is skilled and adept at just talking to people. And I'm sure their family grows tired of their aberrant behavior in this behavioral crisis or psychiatric emergency. So you need to be the person who provides the calming to the troubled waters and just talk to the patient. Because make your peace with the fact that you can't fix whatever their behavioral issue is. You can't fix whatever their psychiatric issue is, but you can affect some bit of change in the way they are behaving right now. You can't take away the stresses. You can't take away the drug and alcohol dependency. You can't take away the mental illness. But from that point forward, you can address the problems. We're the mop-up crew. We're the ones that clean up all the fallout. Always, always, always be on your toes, though, because if you are called for a behavioral emergency, that means this patient is acting outside of what is considered normal. So you can go from having this wonderful, pleasant conversation with someone to the fight of your life in no time flat. And I'll tell you, working for an ambulance service, they couldn't come up with a sum of money that was enough to make me roll around on the floor and fight with people. So when agitation gets to a point that you feel like you are uncomfortable, it is time to leave. That immediately becomes a law enforcement matter, and you are not abandoning your patient because scene safety for you and your partner are paramount to anything else. If you're on the ground rolling around with this patient, the situation is not getting better. Let's talk about some of the mental health care that is going on out there these days. First of all, a huge percentage of the population has some form of mental diagnosis, whether it's anxiety and depression, straight up through to, sociopathic tendencies and everything in between. So most of these problems, most of these mental disorders are handled through outpatient visits. Patients talk to a therapist, they talk to a counselor, they receive some form of medication, and generally, soon enough, these problems begin to get better. As long as the patient follows through on their end of these outpatient visits, we don't often wind up to the point of hospitalization. Most of the time, people that wind up being hospitalized for a mental disorder or a mental illness or a behavioral crisis are people who don't follow through on their end of the treatment. It's difficult to convince someone who has something like schizophrenia, who takes their medicine and begins to behave more normally as far as social standards go, that once they start to feel better, they need to continue taking their medicine. They need to continue seeing their doctor. What do I need to take medicine for? I'm not sick. What do I need a doctor for? I'm not sick. Then the medicine compliance starts to go away some. And that's when we start seeing hospitalizations and behavioral type crises. We'll see patients who, on a week ago Monday, you just brought them to the emergency room because they tripped and fell and they were as pleasant could be. And, things seemed to be going normal. They had clear, conscious, rational thought. Your assessment was just for an ankle injury because they tripped and fell. And a week or two down the road, when they've stopped taking their medicine because I'm not sick, I don't need to take medicine, they are as much of a behavioral and patient management problem as you can physically manage in your ambulance. One of the big problems with the care for the mentally ill in our society now as it sits is funding. They've closed a lot of the institutions that used to be run by, the Massachusetts state government and the federal government, where people could go and receive treatment, and a lot of the programs are really sort of going away. So it's difficult to continue to receive the proper care and treatment, and it's difficult to receive the proper outpatient services when the funding is lacking. And that's where a lot of people slip through the cracks, and we see more hospitalizations and we see more problematic patients because either they can't afford their medicine, they can't afford their treatment, they can't afford their care. And that happens whether it's a mental disease or it is a physical disease. We wind up with a lot of those same problems. There's plenty of underlying causes to all this. It could be social or situational, stressors, things that you would consider stressful, your patient probably considers stressful. Could be a disease process like schizophrenia, could be a physical illness like diabetes. Your diabetic patient is absolutely going to be behavioral emergency 101 because brain's not getting what it needs to be fed. If the brain's not getting what it needs to be fed, it's going to malfunction. The same goes for our alcohol and drug use patients. Those are also likely to have behavioral components to them because mind-altering substance alter your patient's mind, and they alter their perception, and they alter their ability to behave to societal norms.
Those are your keys, yeah.
Also, we could have biological problems.
Baby.
Electrolyte imbalances. Electrolytes carry nerve impulses. We talked about that when we were talking about referred pain. And if your patient doesn't have the proper chemistry inside their body, their brain could be sending off all sorts of messages. Their brain could be sending off inappropriate messages, and those messages aren't being carried and delivered appropriately. Want to know the best part about this whole thing? Guess whose responsibility it isn't to figure out the nature of your patient's behavioral crisis or psychiatric emergency? Yours. We have no hand in that. We have no part in that. You know what this truly is to us? It is an altered mental status patient. And the things that we're held to are, I have to make sure that my patient's not hypoxic. I have to make sure that my patient hasn't had some sort of traumatic event and that's what's causing their alteration. I have to make sure that my patient doesn't have hypoglycemia or hyperglycemia and that's what's causing their problem. I have to make sure their altered mental status isn't relative to shock or any of the other causes for neurological altered mental status problems that we came up with, because that's where it's at for us. We don't need to diagnose. It's not our job to diagnose. It could be an organic problem with the brain from something like a tumor, or it could be a physiological problem with the function of that brain tissue. It could be an illness from trauma, traumatic brain injury, seizure, drugs, alcohol, overdose, withdrawal. It can be almost anything because the brain is such an interconnected, complex organism, complex organ, that anything that affects it is going to affect the brain. Anything that affects it is going to affect the way that your patient thinks. And at the end of the day, our job is to account for our safety, be the best part of that day for the patient that we can be, even if they're not interested in that, and transport them to the hospital where the actual nuts and bolts of how to assess and treat this patient actually take place. Our job is to rule out the things that we can get rid of as not causing this alteration, not causing this behavioral issue, not causing what appears to be this psychological complaint. Because we didn't look just isn't a good enough answer. Our sample history is going to be hugely important to how this patient receives treatment moving on, and what actually the hospital is able to figure out and do for this patient. Asking our mental status questions appropriately, sort of delving into that a little bit more deeply, is going to be of some clinical significance, because people in the middle of a behavioral emergency may answer you, they may not answer you. They may answer you inappropriately, they may answer you inappropriately on purpose. And that information, as they do move through the diagnosis and treatment of whatever it is that's going on with them, is going to actually help the hospital decide, is this patient improving? Is this patient not improving? What else do they need? What could we be missing? What else could we be doing?
What sauce is this?
So I think the last little part I want to go over here is patient restraint. So here are your two criteria for patient restraint. And what I will tell you is, if you have to restrain a patient to your stretcher, documentation is key. Documentation is going to save you down the road if you have to restrain somebody. So it is only to protect yourself or others from bodily harm, or to prevent the patient from injuring themselves. Those are the only times we restrain somebody to a stretcher. We will restrain their one arm above their head and one arm to the stretcher below their head, and always make sure you tie their hands to something that does not move. If you tie it to one of the stretcher rails that moves, as opposed to the frame of the stretcher, they're going to be able to move around, they're going to be able to get enough wiggle room, and they may actually be able to get free. Being adept at de-escalating a problem is way, way better than ever having to deal with restraint of a patient. Even if someone's being transported against their will, if they say, that's it, I'm getting out, my response to that is always the same thing. All right, let us pull over first. Because it's not my place to fight with them. It's not my job to fight with them. And it looks terrible on camera of us rolling around on the ground trying to force somebody back into the ambulance. The next piece I tell them, though, is you can go ahead and get out, but the minute you get out of those buckles, I have to call the police. And that generally buys me enough time to get to the emergency room, especially because we're close to the emergency room here. So the thought of, all right, well, if I don't just go to the emergency room with them, I'm going to wind up going to jail, is generally sort of convincing enough to get them to just go to the emergency room and stop being a pain in the neck. If you have gone through all of your de-escalation techniques and have made the decision that you are going to restrain this patient, it needs to be done quickly, and it needs to be a surprise. You need at least 5 people. There should be one person for each extremity and one person for the patient's head. Always have a plan ahead of time, because once this happens, plans tend to go out the window. You're not going to make it up on the fly. You're not just going to figure this out as you go along. And only the amount of force necessary to get this patient under control and compliance is what you're going to use to get them under the stretcher and get them into the ambulance and get them transported on their merry way. Get them onto the stretcher and be finished with it. The person who is behind the patient when you're going to restrain them is the one who launches this whole bit of sneak attack, because if they can see you coming, they can prepare for it. So whoever is behind the patient physically when it's time for this to all happen is going to be the one who launches the attempt at restraint. Don't underestimate your patient, especially in someone who is having some sort of behavioral or psychological issue. They may be a little bit more difficult and a little bit more wiggly than you would expect. Let's see, what else? Never leave your restrained patient unattended. Monitor your patient closely. There are cases and there are times where your patient could struggle against the restraints so long and so hard that they actually go into cardiac arrest. So if you're going to restrain a patient, you should also have an out, have a plan. We need to transport quickly because we can't allow this patient to struggle against those restraints forever. We could also call for an intercept and have this patient chemically restrained so that they don't sit there and fight against the restraints and so that they don't accidentally die from struggling with the restraints. There are a ton of options. There are a ton of moving parts, and our safety is really what is absolutely the most crucial, pivotal point of all of this. Now, I know in the news as of late, attacks on public service people and EMTs especially, there was just one in the news last year or the year before, right here in the Boston area, have been sort of a big ticket item. Thankfully, they do not make up a large population of the people we see on a regular basis. But always be alert for the signs of potential. One of the greatest predictors of the future is the past. So if your patient has a history of violence, either towards you or towards others, it is quite likely that they are very well versed in the ability to commit more violence. Look at your patient's posture. A patient who is, pacing like a caged animal, or obviously visibly trying to restrain themselves and hold themselves together, is someone who is only a few more aggravations away from lashing out. Look around the scene. Is there anything nearby that this patient could use to harm you or to harm your partner? Also, evaluate the scene for things like, is there some unusual quiet? Is there lots of noise? Do I hear what sounds like fighting? Pay attention to the way your patient is speaking. Pay attention to the way your patient is behaving. And you won't wind up in a situation that you weren't expecting, because it is very easy to just pull the ripcord and bail right out of this, as opposed to being the last person to know that you were about to wind up in an altercation. When in doubt, get out. There's no sense and absolutely no reason to wind up in any form of physical altercation with your patient ever. There's people that get paid handsomely to do that, and we're not them. As far as figuring out and diagnosing their psychiatric conditions, sorry, that's not our jam. We monitor and care for the things that we know that we can. We transport them in as safe a manner as we possibly can, and just be involved in your patient's care, and things tend to go a whole lot better. I used to work with a woman who said, it doesn't cost nothing to be nice. And really, you'd be amazed at how far that can take you, even with someone who is, behaving erratically or having some sort of stress-induced or psychologically induced behavioral problem.